So welcome to Notable Perspectives. I'm your host, Aaron Neinstein. Our guest today is Michael Hancock, Executive Director of Operations Transformation at Castell. In his role, Mike leads the Operations Transformation and Care Traffic Control teams that support Intermountain Medical Group and affiliate partner clinics. He's worked for Intermountain Healthcare in service line, geographic operations, and practice management roles, leading a variety of outpatient clinics and hospital outpatient services. Mike, welcome to the show. Great to see you.
Thank you. Good to be with you.
So let's start at the beginning. What inspired you to get into healthcare in the first place?
Man, I think I've just always had an interest in health, well-being, and kind of the business side of things. I remember when I at first, maybe as a teenager, learned about what health administration was. I was surprised. I thought that doctors were just the ones that ran the health system, which no offense to any, but I'm glad that that's not purely the case. So I think my early inspiration was just an interest in operations, leadership, and management of something that was a little bit more than just business, but something with more purpose. And healthcare definitely has a whole lot of that. So yeah.
And your role is an interesting title, Operations Transformation.
Yeah.
So we hear a lot about operations. We hear about transformation. Tell us a little bit about Operations Transformation, where that came from and what the role entails.
Yeah. So in my first 6 or 7 years with Intermountain Health, I had the opportunity to again lead several different ambulatory practice operations. And one of the one of the last roles that I was in was one where we were asked to really turn the way that we delivered primary care on its head and figure out a new model that was value-based and preventative in nature, and one that drove costs down while keeping quality, experience, and access high. And so in doing that, my team and I, my senior leaders and others on my team really sought out just trying to figure out what this care model might be. And we eventually came up with what we called reimagined primary care. So we created a pilot where we launched this new model of care with about 75 providers. Pretty large pilot.
Yeah, I was going to say that's not a small pilot.
It's a health system for a lot of groups, but it was a pilot in our case, and then it eventually turned into the model that was to be adopted throughout the entire medical group. And so the process of operations transformation, as it started with us, was really implementing all of that new model, or scaling that entire model from the 75 to about 400 to 500 providers throughout the entire Intermountain Medical Group in Utah. So that transformational piece of it is really transforming operations into a value-based model that's again focused on high value, cost, lowest possible cost, but making sure that quality remains high and maintaining good experience all along the way.
And so is the operations transformation something that has a beginning and an end, or now that you've done that pilot in primary care, are you working on scaling it or onto other areas of the company, or what happens next?
Yeah, good question. So we're pretty mature in primary care, but that is only scratching the surface when it comes to the transformation and the improvement that's needed in healthcare as a whole. So I would say we're 3 to 4 years into the transformation process in our Utah medical group. But when Castell, Intermountain's pop health company, was created, we had a different Intermountain Health that we were supporting at the time. Since then, in about 2019, when Castell was created, Intermountain has expanded into 3 or 4 new states. And so we've got a health system now in Idaho, in Nevada, and in Colorado. So at this point, the transformation continues to be within primary care now in those new markets that we're in. And now we're doing a whole lot of work in trying to determine what value-based care looks like in specialty spaces also. So I think there's a lot of transformation work still to be done in the acute care space and hospitals, and in specialty care in the ambulatory space. So we're getting into those phases right now. And I think to just plainly answer your question, we've only just begun.
Yeah.
There's a lot of work to do.
And if another health system leader were coming to you and asking you about the primary care transformation you've done towards value, and asking, what are 2 or 3 of the most high yield or high leverage things that you did, what's your answer for them?
Yeah, they do come to us and ask us that a lot. Can't understate the importance of physician engagement and physician leadership involved in the transformation. We've got Castell and Intermountain Health as a whole is a physician-led organization, and so it's great to have a dyad partner as an administrator to be able to help me reach physicians and have conversations with more legitimacy than I do. We laugh all the time because I can go in and say something, and then my physician partner can repeat me and get a whole lot more buy-in than I ever did. And so,
Interesting. So the messenger matters.
oh, the messenger matters a whole lot. So, but it's a great partnership because where their strengths are, they make up for where I might lack and vice versa. So, I can't underestimate the importance of physician leadership. I think having them involved is really big. And then I think it needs to remain, um, I mean, a communication plan and approach that in every conversation that you have, you're stating the why and connecting it back to bigger purpose. I think a lot of the times when we started getting into value-based care and we start to think through, okay, how might we segment our populations and provide, a more whole wraparound service offering to value-based partners and value-based payers. The question then becomes, well, what are we doing with the fee-for-service patients? Are we just giving them, a lower quality of care? Are we just leaving them out to with just less than type of approach? And you got to be really careful with that and make sure that providers understand that the clinical care, that this does not get in the way of the clinical care that you provide, whether it's a value or fee-for-service patient. Always make sure that you're doing the right thing, providing the right clinical care. Just where those wraparound services come from and maybe the quality with which they're delivered might be a little different. We've got to hold the payers accountable to make sure that they're providing the services when they should be, and when it's been delegated to us for value-based patients, then we do them in the best way that we can.
I assume with a lot of what you're talking about that analytics becomes really important. Can you give an example of one place where you've used data, where you've used analytics to really help you move this model forward?
Yeah, you said it. Analytics, we couldn't do the work that we do without analytics. So to give you a little sense of the teams that I lead, we have a team that we affectionately call Care Traffic Control.
Great title.
Yeah, the Care Traffic Control team is made up of about 260 care coordinators who are non-clinically trained individuals that work remotely supporting primary care teams. So if you were a primary care physician working in Salt Lake City, you would have a care coordinator that we call a quality care coordinator and a social needs care coordinator. And their role is to really help identify patients throughout the entire provider panel that might need some type of primary care support. So our transition from our old model of care to our new model of care was really a view from, let's not just pay attention to the patients who we see who are on the schedule.
Yeah.
The ones that we know need help, the ones that we see regularly. But there's 1,000+ patients that this provider sees on their panel. How might we be able to prevent issues from happening with them down the road by staying on top of their primary care needs? And so these care coordinators and care managers and documentation and coding specialists or other members of the team, they are really tasked with helping to keep an eye out for the patients who are on the provider's panel, but not necessarily actively receiving care. Now, these might be people that are going inappropriately to the ER or getting admitted to the hospital because they're not regularly seeing their doctor, keeping up on preventative maintenance. And when the time comes that they need care, they don't even think of their primary care doctor. They go to the urgent care or they go to, go straight to the ER. And people who may just have these worsening conditions that are just not actively being managed by their PCP. So we can't expect a provider to just be able to do all that by themselves. So if we want to make a difference and create a new model, I think we determined early on we needed to surround the providers with a team that could help them out with all of those things. So that's essentially what the care coordinators and care managers do, completely assisted by data and analytic tools. So we have analytic dashboards. We've got algorithms that help predict patients who are high risk or are in danger of becoming high risk because of their their illness burden or other issues or their socioeconomics. And then those analytic resources and tools feed into workflow tools that they use to do outreach to those patients and to say, hey, you know what? We haven't seen you in for a regular checkup with your doctor for about 3 years, and we just want to see how things are going. Or, we know that you, we care about whole person care, and we want to make sure that you're taken care of when it comes to transportation, housing, and food needs. We're talking to a lot of patients about those things. How are you doing in those areas? So just trying to take care of those needs and predict and anticipate issues that patients might encounter so that they're not running across situations where, we've gotten to them later than we could have otherwise.
That's incredible. So I'm a practicing endocrinologist.
Yeah.
My practice is diabetes, and as I hear you talking about this, I'm feeling very jealous of I'd love to have some care traffic controllers to help me out, and I'm sure many people listening are feeling the same. How do you think about the financial model to make those possible, and what ratios do you have of care traffic controllers per size of patient panel or per number of providers that they're supporting?
Yeah, no, great question. I think when it comes to the financial piece of it, we've got to make sure that we're creating a adequate value proposition to make sure that those care coordinators and care managers are, they're giving an adequate return. They've got to be paying for what they're producing, and so with that also we also are really careful to make sure that so I guess to that piece, we're very intentional about the work that they prioritize. So I think the biggest bang for their buck that they can add there is helping to avoid admissions or readmissions to the hospital, and then unnecessary visits to the ER. I think that those are one of their main areas of focus. In addition to that, we really put an emphasis on how they can help get providers get patients in to manage those diabetes. So there might be protocols in place for patients who have an A1C over 8, and making sure we get them in quarterly or according to their correct clinical protocol. So we're very, very deliberate in making sure that there's a set of standard work those care coordinators are always working on, a prioritized list of patients that they're working with. And then it is an ongoing, I guess, developing model to figure out the best ratio of patients that that a provider can have. So in our early days, it was, I hate to say guessing.
Yeah.
It was very informed estimations,
Okay.
we'll call it. And so in those early days, we assumed that one care coordinator FTE could support about 5,000 or so, a panel of about 5,000 patients. Now, that doesn't mean that they're talking to 5,000 patients actively. It might be, between these 5 doctors, there are 5,000 patients, and we talk to 800 of them on a regular basis. And then the other 4,200 are those that we'll keep an eye on. And if they pop up on our reports, we'll actively reach out. But our latest evolution of staffing for care coordinators has been with by creating a risk prediction algorithm. If you look at let's just say a geriatric practice versus a family medicine practice, it's not very logical to think that I could just give the same amount of care coordinator help to two providers in those two providers in those specialties. So our approach has now been we're using some algorithms and building some data models to be able to say, all right, well, with this practice, given the socioeconomics, given the illness burden of these patients and several other factors, we would need an FTE and a half of support to the geriatric practice and about a half of an FTE to the family medicine practice, so that we're just adequately giving practices the amount of help that they need.
And so you're adjusting those ratios based on severity of illness, demographic, type of practice.
Yeah, socioeconomics.
That's really interesting. And are the care traffic controller, how has the makeup of the staffing of the practices changed from the before times to now? Are these roles additive to the typical staff that you would have in a practice, or have you transformed the roles of people who might typically be a medical assistant How has that makeup of the practice staffing changed?
Yeah, it's evolved. It's definitely evolved. So in a typical practice, traditionally, you might have a receptionist at the front desk and a medical assistant. Some practices may have a nurse thrown in there as well. Um, Initially, in our approach, we had a role that we call the care guide, and the care guide, kind of a supplemental person focused on quality measure performance. And so they were focused on trying to get those HEDIS measures closed, and they were really working on trying to help manage chronic illness and supplement the work that our nurse care manager did. And then as time went on, we realized, there's probably an opportunity for us to add a role that's focused on social determinant of health management and connecting people to resources and being a real community expert. And those conversations and that work can be time consuming. That can be a 3-hour conversation in a day with one person to get them up connected with food and housing and utility resources. And we just thought, I don't think we can have our typical care guides doing that.
Mhm.
So what we did is we adjusted the name to become care coordinators, and then we broke them out into social needs and quality care coordinators.
As two separate roles.
Right, as two separate people, two separate roles, and so now each primary care doctor is equipped with a quality and a social needs care coordinator, and though they work virtually, we've really worked to just embed them into the team.
Mhm.
So if they live in a geographic, proximity of the clinic, they'll round to the clinic maybe once a month or so, for a couple of hours to build relationships and establish establish some more connection there. And then they have several times a week huddles with their entire team. So these are patient focused, patient level huddles where they'll say, "All right, team, this week it looks like with Dr. Jones, we've got these 5 patients who have been in the hospital in the last week, and this is their return visit
So
to."
they will pick out the highest risk or the most
Yeah,
pressing patients to talk about.
exactly. Yeah, they'll also say, "Dr. Jones, here are the 3 or 4 patients who are currently in the hospital, and we anticipate they'll be be discharged here soon. I'll go ahead and call them and we'll make transition plans. I'll get them an appointment here. They also need to see the rheumatologist, and I'll set up an appointment with the rheumatologist, and they'll just talk through making sure those transitions are safe and as positive as possible. That's also an opportunity for the provider to say, you know what, this person is a great candidate for our nurse care manager to come and to spend time with. So we might establish a connection there. We might look at other patients who are in less acute circumstances, and in those conversations, we'll talk through, hey, here's the list of 50 people who are due for a mammogram. I was able to connect with 30 of them, schedule mammograms with 20 of them. But doc, there's these 5 that just will never even answer the phone.
Mhm.
Looks like they might respond better to a call from you, or I saw 2 of them are coming into the clinic this week. Can you talk to them about the mammogram then? And so it's an opportunity for us to really chat together with a fully engaged group, with the provider as the quarterback,
Mhm.
and the provider just helping to direct plans on how they can best use that team. So it's really helped us to get over that remote challenge of them not being physically down the hall
Yeah.
from them.
What a massive shift. I
Oh
mean,
yeah,
just completely transformational shift in care
yeah,
model.
yeah.
Again, I assume there's going to be a lot of people who listen to this and are very interested in taking some of the lessons and taking them back. So you mentioned a little bit around the business case being built around readmission prevention. Anything else you look at as you think about looking at outcomes and the success
Mhm.
of this model? What else other than admission prevention uh, are your success
Mhm.
metrics?
Yeah, quality is a big one. We have a payment model that we administer as the managers of risk between the payer and our health system, Intermountain. So what we do is we have a very clear list of quality measures that we keep an eye on that are very aligned with HEDIS. And from there, rather our Castell's approach is, rather than saying, "Okay, you're gonna get better at this quality performance, and we'll provide reports to you every month to tell you how you're doing," we say we'll provide that reporting, but we'll also be there to with some people resources to help you do well. And that's what the care coordinators do. And so these quality care coordinators are actively working on those annual wellness visit scheduling, the diabetes bundle, so diabetic eye exams, diabetes that is just out of control, and also cancer screenings, medication adherence, and other things like that. So there's actively someone doing outreach to try to make sure that the patients who will help the provider close the measure and hit their target quality performance, they've always got someone that's working on it rather than a purely in reach approach, is what we call it, where the only opportunity to talk about it is if the patient comes into the clinic.
Mhm.
So that outreach approach, well, that in reach approach where you're talking to patients about their quality, related work and care gaps that need to be closed, and their health maintenance, that is supplemented by someone always working on it. And also importantly, always bringing feedback to the provider on how the provider's doing. And then I think all along the way, an important part for us is aligned incentives.
Mhm.
So in addition to there being a payment model between Castell and the health system, there's also aligned compensation for the provider so
Mhm.
that they receive some type of benefit money wise for the effort they're putting in there. And then we also even have a program where care coordinators themselves are able to get a bump of money for the work that they do in helping providers achieve good quality performance.
What's the range of provider compensation, the sort of like the scale range of their compensation
Yeah.
that is attributed in this model? We've heard all the way from
Yeah.
100% to 1%. What have you
Yeah.
found is the sweet spot for incentives?
Oh man, I'm sure it's different for every system. And it's evolved for us. I mean, we're probably 5, 6, 7 years into having some type of value-based incentive for them. So our providers have they have a base salary, and then the incentive, and then the quality work is additional incentive on top of that.
So it's a
So
carrot, not a stick.
exactly.
Yeah.
Yeah.
Now, as you see what is quickly becoming possible with AI right now, and you think about your next 3 years and sort of your crystal ball for
Mhm.
taking this model that you've developed and what might be possible in the future that hasn't been. What are some of the
Mhm.
things that you're excited to do next?
Yeah. I just want AI to answer my emails. That's all I want. If I can figure out how it can answer my emails so I don't have a big stack. No, I think, some of the things that we're doing with Notable right now is automatic or just process automation. Um, those care coordinators add a ton of value. They're also expensive. When you take
Mhm.
260 people doing anything, that adds up. And
Yeah, you
so
caught my attention at
right.
260.
Yeah, yeah. And when you are an innovative organization like we are, a lot of the times we try not to just wait for technology to catch up with us. Otherwise, we'd be waiting for a while. What we've been trying to do is say, okay, well, if we have a service that we can deliver now, let's get it started, and then we will work on getting the technology into what we do, rather than saying we're not going to start until technology's caught up, right?
Mhm.
So with that, we've done a lot of robotic process automation to help do things like chart scrubbing
Mhm.
and do let's say a care coordinator sees that a patient is coming in for their annual wellness visit with a provider next week,
Mhm.
and this patient has lived all over the place. So what we've done is we've worked with Notable on some robotic automation there, where they can actually do a chart scrub through a bot
Mhm.
that will actually go through and scrub their entire record and pull out just whatever they can find. So that
Mhm.
might be, a mammogram, or let's say a colonoscopy that happened 6 years ago at a health system that's not the one that that's not in the Intermountain Health System, and it surfaces that. And then a care coordinator is able to see that and say, oh, actually, look at that. We don't even have to close that gap and do an outreach call for them because they already did that at another health system. Documentation which we wouldn't have seen otherwise.
Mhm.
So that saves us. I mean, that saves a lot of individual digging through a health record and just not fun work by a care coordinator. And when you multiply that out by 260 people, that happening constantly, that's a lot of time savings created. And another thing we're trying to do right now, I mean, in a lot of ways, healthcare tech is in the stone ages in what
Mhm.
in the way that we operate. And so other things like how might we be able to use text messages and emails to close gaps in care and get people scheduled for those visits through self scheduling without ever even having to have a person call them.
Yeah.
There is it might not be everyone, but there is a good group of people out there who might get a text, respond to it by clicking a link that'll take them to scheduling their annual wellness visit. They go on there, they schedule it through the health systems portal, and boom, they've got an AWV scheduled, and care coordinator or a human never had to do a thing.
Yeah.
So,
So it sounds like lots of ways to try to give your care coordinators sort of maximum leverage on
yeah,
the work they're doing.
right. And just have, bots do stuff bots should do, and humans do things humans should do. If we can create situations where care coordinators can have work just completely taken off their plates, then we're going to try to do it.
Yeah. As you try to stay current with the industry in this space of
Mhm.
of care delivery transformation and operational transformation, what are your go-to sources for reading and staying current? What do you
Yeah.
recommend people read if they want to learn about this space?
Intermountain's a large enough organization that we're fortunate. Our strategy office really has there's a daily email where they actually go through and they collect
So we just
as
need
much
to
as they
hack into your
can.
email and then we get
Exactly.
the goods.
Get on our email distro. But a lot of that comes from I think modern healthcare is a big one that we go to, and a few other, I mean, Becker's and a couple of other pretty commonly known names that are the main places that we go through to collect that information. So I'm fortunate. I don't necessarily have to go out and find that information very often. It's literally at about 4:03 a.m. every
All right,
morning.
I know who to call
I
for
get
the
this.
for the quick summaries of high yield
It's
information.
the market intelligence email that just comes through delivered right to my door. So, but I know that everyone is not as fortunate to have an infrastructure like that. But I think that and some of those sources that I mentioned are probably the best places that
Yeah.
that you can go to.
Anything else you'd like to share before we wrap up?
And there is, I mean, a term that we use all the time is we are building the plane as we fly it. I think a lot of groups say, yeah, how is Intermountain and Castell just always kind of on the forefront of a lot of this work? And I think it's because we're not afraid to begin trying. We don't necessarily. One of my leaders that's here with us yesterday said, we don't necessarily say ready, aim, fire. We say fire, ready, aim, which may or may not be the best approach. But I think the point in that is saying, don't be afraid to start taking action and start testing and trying out things first and then iterating to make them work well. If you want to move down in a value-based mindset, you could sit here all day thinking, gosh, let's get this approach exactly right. Let's create our perfect model and then let's go implement it. That's going to take you years to figure out even how to do it. And your best practice on developing and establishing a value-based care model is going to be by starting. So I think I just encourage groups to start somewhere and iterate as they go, because that will be the best learning by actually learning how to do it as you go. So
That's I mean, very inspiring message and words. I think there's a lot of fear in healthcare about trying to get things right and, commonly thought of as a risk averse culture. So
mhm.
very inspiring to hear that Intermountain is taking that approach. So I think
Yeah.
that's a great place to close. And thank you so much for
Yeah.
the really inspiring conversation, Michael.
Thank you. Appreciate it.